If you're over 65, the blood pressure number your doctor wants you at is not the same number they want for a 40-year-old. And most people don't know that, including some people who've been chasing the wrong target for years. There are two very different camps in modern medicine right now. One says get your systolic number under 120, as tight as you possibly can. The other says for a lot of older adults, that same tight target can actually do more harm than good. Both camps have real research behind them. Today, I'm going to walk you through exactly what that research says, where it agrees, where it doesn't, and what that means for the number you should actually be aiming for. By the end of this video, you'll understand the two major blood pressure targets doctors argue about, why age and frailty change the math, and the specific signs that tell you whether you're the kind of person who benefits from a tighter target or a more relaxed one. The last part of this, the piece about frailty and falls, is the one most videos on this topic skip entirely, and it might be the most important part for a lot of you watching. Before we get into it, drop your current blood pressure number in the comments and tell me what your doctor has told you your target should be. I read these, and honestly, the range of answers people get from their own doctors is part of why I wanted to make this video in the first place. Here's the thing to understand before any of the specific numbers make sense. Blood pressure management for older adults comes down to balancing two competing risks. One risk is what happens if your blood pressure stays too high for too long. Damage to your arteries, your heart, your kidneys, your brain. The other risk is what happens if you push it down too aggressively, too fast, especially if you're older or frailer. And that's things like dizziness, falls, and reduced blood flow to organs that don't tolerate low pressure well. Every recommendation you're about to hear is really just an attempt to find the point where those two risks balance out. And that balance point is different depending on your age, your overall health, and a few specific factors we're going to walk through. Let's start with what normal actually means by the numbers. Current guidelines from the American Heart Association and American College of Cardiology define normal blood pressure as under 120 systolic, that's the top number, over 80 diastolic, the bottom number. Anything from 130 over 80 up to 139 over 89 is called stage 1 high blood pressure. 140 over 90 and above is stage 2. Those categories apply the same way regardless of age. What changes with age is the target doctors actually treat toward, and that's where it gets more interesting. Get a home blood pressure monitor if you don't have one already. An upper arm cuff, not a wrist one. They're more accurate. Take your readings sitting down, feet flat, after resting quietly for 5 minutes. A single reading in a doctor's office can be thrown off by nerves, what's called white coat hypertension. So having your own numbers from home gives you and your doctor a much clearer picture. Now let's talk about the case for going tight, under 120. This is where a landmark study called SPRINT, the Systolic Blood Pressure Intervention Trial, comes in. It followed adults 50 and older with high blood pressure and additional cardiovascular risk factors, comparing a standard treatment target of under 140 systolic against an intensive target of under 120. The intensive group had meaningfully lower rates of heart attack, heart failure, stroke, and death from cardiovascular causes. This was a big enough finding that it genuinely reshaped a lot of blood pressure guidelines afterward. So, if lower is genuinely better for your heart, why isn't everyone simply told to chase 120? Because of what happens when you push that number down too hard, too fast. And that's exactly where the next piece of research comes in. The SPRINT trial also found something else. The intensive treatment group had higher rates of certain side effects: low blood pressure episodes, fainting, electrolyte problems, and acute kidney injury. These weren't life threatening in most cases, but they're not nothing either, especially in someone who's already frail or dealing with multiple health conditions. This is exactly why a separate, more conservative guideline from the American College of Physicians and the American Academy of Family Physicians recommends a more relaxed target of under 150 systolic for adults 60 and older who don't have specific high risk conditions, only tightening toward 140 or lower if the person has already had a stroke, has diabetes, or has high cardiovascular risk. Let's make sure that number doesn't blur together with the ones from before. Remember, 140 over 90 is where stage 2 begins. So, this more relaxed guideline is essentially saying for some older adults, sitting just inside stage 2 is an acceptable trade off if it means avoiding the side effects of more intensive treatment. That's the actual disagreement in one sentence. Both of these guidelines are legitimate, evidence based, and still in use today. The disagreement isn't about bad research. It's a genuine, ongoing debate about where the risk benefit line sits, and it depends heavily on the individual. If this is helping make sense of some conflicting advice you've gotten, do me a favor and send this video to someone who's been confused about their own numbers: a parent, a spouse, a friend who's mentioned this exact disagreement with their own doctor. This is exactly the kind of thing that's easier to sort out together than alone. So that's the tension on paper: heart protection versus side effects. But there's a third factor that decides which side of that tension matters more for you specifically, and it's the part that gets left out of almost every blood pressure conversation: frailty and falls. This might be the single most important factor for anyone over 75, or anyone who's had a fall in the past year. As we age, a condition called orthostatic hypotension becomes much more common. That's a drop in blood pressure when you stand up, which can cause dizziness or fainting. If your blood pressure is being pushed down aggressively with medication, and you already have some degree of orthostatic hypotension, standing up quickly can genuinely put you at higher risk of a fall. And for an older adult, a fall isn't a small thing. It's one of the leading causes of serious injury and loss of independence. This is exactly why frailty, fall history, and how well someone tolerates standing up are supposed to be part of the conversation with your doctor about your target, not just your blood pressure number sitting in a chair. Ask your doctor specifically to check your blood pressure both sitting and standing at your next visit. It's a simple 30-second check that tells you and your doctor whether orthostatic hypotension is part of your picture, and that answer should genuinely shape what target makes sense for you. Now let's talk about what actually moves the number, beyond medication. Whatever target you and your doctor land on, the way you get there matters just as much. And honestly, this is the part most people can act on tonight, without waiting for an appointment. Start with sodium, because it's usually the biggest lever. Most of the sodium in the average diet doesn't come from the salt shaker. It comes from bread, canned soups, deli meat, and restaurant or packaged food. often in amounts that surprise people once they actually check a label. Cutting back here consistently can move systolic pressure by a meaningful amount within a few weeks for a lot of people. Movement is next, and it doesn't need to be intense. A daily walk, even 20 to 30 minutes at a comfortable pace, has real, measurable blood pressure benefits, largely by helping your blood vessels stay more flexible and responsive over time. Weight and alcohol move together, honestly. A modest weight reduction, 5 to 10% of body weight for someone carrying extra, has been shown to meaningfully lower blood pressure on its own. And cutting back on more than light drinking works the same way, often faster than people expect. And stress is the one that's hardest to pin a number to, but it's real. Chronic stress keeps your body in a state that works against everything else you're doing, which is part of why things like consistent sleep and any kind of regular relaxation practice show up again and again in the research on blood pressure control. None of these replace medication if medication is what you need, but they work alongside it. And for some people with mild elevations, these changes alone can be enough to avoid needing medication in the first place, or to need less of it over time. I think about people I hear from who are in a really common situation. Let's call her Grace, mid 70s, been on blood pressure medication for years. Her numbers at her last checkup were 118 over 72, right in that tight under 120 inches zone her doctor had been aiming for. But a few weeks ago, she stood up from the couch in the middle of dinner to grab something from the kitchen, and the room tilted on her. She grabbed the back of a chair, stood still for a second, and it passed. She didn't mention it at her next appointment. It seemed too small, too quick to bring up. Nobody had ever connected that moment to her treatment target because nobody was looking for the connection. That's exactly the conversation worth having directly with her own doctor. Not should I stop my medication, but is my current target still the right one for me, given how I'm actually feeling day to day? That's a completely different, much safer question, and it's one your doctor can actually work with. Here's where I want to be very direct with you. Nothing in this video means you should change your blood pressure medication, your dose, or your target on your own. The whole point of walking through this research is so you can have a smarter, more specific conversation with your own doctor, not so you can make this decision by yourself. If you've been feeling dizzy, lightheaded when standing, or you've had a fall, that's genuinely important information your doctor needs. Bring it up directly, and bring up this idea of checking your pressure sitting versus standing. That single conversation could meaningfully change what target makes sense for you. So here's what I'd actually do with everything we just covered. 1. Get an upper arm home blood pressure monitor if you don't already have one, and start tracking real numbers from home. 2. Write down your last known blood pressure reading and whatever target your doctor has given you, so you have it ready for your next conversation. 3. Ask your doctor specifically whether your target should account for your age, frailty, or fall history, and ask them to check your blood pressure sitting and standing. 4. If you've had any dizziness on standing or a fall in the past year, mention it directly at your next visit, even if it seemed minor. 5. Keep working on the lifestyle side. Sodium, movement, weight, alcohol, stress, regardless of what target you land on, since those changes support whatever number you and your doctor decide is right. At the end of the day, this isn't really about chasing a perfect number. It's about staying steady enough on your feet to keep doing the things that matter. Walking to see your grandkids, driving yourself to your own appointments, feeling like yourself. The right blood pressure target is the one that protects your heart without putting your independence at risk. And that's a genuinely personal answer, not a one-size-fits-all one. Everything in this video is general health education, not personal medical advice. If you're managing an existing condition or taking medication, please talk with your own doctor before making any changes. This content is meant to work alongside your care, not replace it. If this helped make sense of your own numbers, subscribe and hit the bell so you don't miss what's coming next. I've got a video coming up on the sodium sources most people don't realize are affecting their pressure, and it's a smaller list than you'd think. I'll see you there.